Okay, here we are. So now we have 64 participants in the meeting. So I would like to start the webinar meeting. So good afternoon and good evening attendees all across the Asia. Welcome to the 23rd FARO webinar hosted by MOSTRO, IRIS, and Aurora. So my name is Unurjargal from the National Cancer Center of Mongolia, and I will be the moderator today. So for today's agenda, we will start with a talk from the exceptional speaker, Dr. Odontuya Gonchig. He will talk about radiation therapy for stage 1 non-small cell lung cancer, issues and radiation techniques. Afterwards, we will have about 15 to 20 minutes for answering questions and also comments from our delegate panelists. During the webinar, all the attendees, you can drop the questions in the chat box, and you can find chat box from the bottom of your screen. So now I would like to proceed with the opening remark. I would like to invite Dr. Rajesh Vashistha, Vice President of FARO, to give his welcome remark. Please, Dr. Rajesh.
Good afternoon and good evening, everybody. Professor Dr. Srinivas Chilukuri and Professor Nagata, and my dear colleagues, faculty members, and dear speaker. Now I welcome you on 23rd FARO webinar on non-small cell lung cancer stage 1 disease. The lung cancer disease is increasing now, and to take decision to go for surgery or radiotherapy is difficult. But result of radiotherapy is now good with the recent advances in techniques. I will like to thank Dr. Mann for selecting and choosing good topics and continue educating all of us during this period by webinars and improving knowledge of everybody. I will appreciate Professor Nagata for keeping FARO active and alive by motivating everybody to work and work. Thanks, Dr. Nagata. Hoping doing in future also. So, for this webinar, Mongolian Society and their President, Dr. Odontuya Gonchig, with the man for choosing speakers. This is Dr. Yang Gu Su and panelist Uranchimeg, Dr. Harada and Srinivas Chilukuri. All are very good, and I hope after this webinar, you will improve, you will have more knowledge in the treating the lung cancer stage 1 and fighting with the other specialty in surgeons and medical oncologists to do this. All the best to all of you. Thank you.
Thank you very much for your opening remark, Dr. Rajesh. Now, I would like to invite Dr. Odontuya Gonchig, the President of MOSTRO, to give her opening remark. Please, Dr. Odontuya.
Thank you all the members and College of FARO. Welcome in the 23 and FARO webinar that this being organized my MOSTRO. It is my honor to take this opening greeting to all of you. I would like to thank you, this distinguished speaker, dear Yang Gonchig, and all the panelists who will be contributing this webinar. This webinar has been supported technical by IROS, and I would like to thank IROS Indonesian Radiation Oncology Society and also IRO. In the IRO, Indonesian Radiation Oncology resident assistant to their tremendous work. So now I would like to conclude my opening speech, and I hope all of you will enjoy this webinar. Thank you.
Thank you very much for your opening remark, Dr. Odontuya. So before moving on to introducing our panelists and the speaker, I would like to take a picture, all of us beforehand. So please, Give your camera, please. Thank you.
राजेश कैमरा ऑन कर देना.
So are we taking?
Yes, I will help for taking the pictures. So I will take the picture in 3, 2, 1. Everyone smile. Okay. Maybe one more time in 3, 2, 1. Okay. Maybe one more shot and give us the best smile. 3, 2, 1. Smile. Okay. Thank you very much.
Yeah, thank you, everyone. So now I would like to introduce our team of panelists, Dr. Uranchimeg Tsegmed from Mongolia. She's a radiation oncologist and now working as a chief operating officer at the NCC of Mongolia. Along with her, we have Dr. Hideyuki Harada from Japan. He is the chief of the Radiation Therapy Division of Radiation and Proton Therapy Center at the Shizuoka Cancer Center of Japan. And along with them, we also have Dr. Srinivas Chilukuri from India. He's a radiation oncologist and now working as a senior consultant at the Apollo Proton Therapy Center of India. So coming toward to delegate speaker, Dr. Yang Gonso, he is currently working as a consultant radiation oncologist at the Proton Therapy Center, a research institute and hospital, National Cancer Center of Korea. He will talk about radiation therapy for stage 1 non-small cell lung cancer issues and radiation techniques. So I would like to invite Dr. Yang Gonso to start with his presentation. Please, Dr. So.
Oh, thank you for kind introduction, and it's my honor to talk here for our webinar. So I start today's my presentation. So there is no conflict of interest. So today I'm talking about SABR treatment for stage 1 lung cancer. So previously, stereotactic body radiotherapy, SBRT term is more frequently used, but recently, stereotactic body ablative radiotherapy, SABR, is more frequently used. I think SABR means knife, so I think SABR sounds more appropriate for local treatment. Anyway, SABR has played an important role for early stage non-small cell lung cancer, particularly for inoperable patients. So today I'm talking about SABR versus surgery and SABR for centrally located tumor and single fraction and multi-fraction SABR and techniques for SABR. So first, I'm talking about SABR versus surgery. Yeah, this study is published on Lancet Oncology in 2015. So as you know, there are two prospective randomized trials to compare SABR and lobectomy for stage 1 non-small cell lung cancer, STARS and Roger trial. But these two studies is only closed due to low patient enrollment. Therefore, in this study, performed pooled analysis, enrolled patient in STARS and Roser trial. As a result, total 58 patients were analyzed in this study. Among these patients, 31 received SABR and 27 received surgery. In this study, recurrence-free survival, you can see in panel B, so recurrence-free survival didn't show difference between SABR and surgery. But there are 7 patients deaths during follow-up period. Among these, 6 was occurred in surgery group. So 2 from cancer progression, 1 from secondary primary lung cancer, and 1 from surgical advanced event, and 2 from comorbidity. Anyway, so after treatment, post-treatment mortality was very higher in lobectomy group. Therefore, in this study, SABRE showed superior overall survival than surgery. And yeah, as I said, the STARS and ROSAR trial was already closed. So the researchers of STARS trial continued the single-arm prospective study that is revised STARS trial. And the authors of this study compared the outcome of revised STARS study with other prospective trial patients treated with lobectomy. So in this study, SABRE and surgery didn't show significant difference in overall survival, progression-free survival, and cancer-specific survival. Therefore, yeah, the authors of this study concluded that SABRE is not inferior compared with lobectomy. Next study is retrospective study, but yeah, this study compared the larger number of patients. So in this study, yeah, they compared patients treated with SABRE more than 100 gray of BED, and they compared these patients treated with lobectomy. Therefore, yeah, 39 patients treated with lobectomy and 165 patients treated SBRT was compared in this study. So according in this study, so local recurrence and regional recurrence was superior in patients treated with lobectomy, and distant recurrence was not difference between treatments. So in univariate analysis and multivariate analysis for local recurrence, so lobectomy was superior than SABRE. I'm talking about another retrospective study compared stereotactic body radiotherapy versus delayed sublobar resection for stage 1 non-small cell lung cancer. Yeah, as you can see here, this study was published in 2020. So this study performed the era of COVID-19 pandemic. Therefore, they want to test immediate SABRE and delayed surgery due to COVID-19 infection. So the data source was National Cancer Database, and they found patients treated between 2004 and 2015, and they selected 570 patients treated early SABRE and 475 patients received delayed wedge resection. According to their study, yeah, the patients treated with delayed wedge resection showed superior overall survival than early SBRT. In matched analysis, this superiority of delayed wedge resection was maintained. And they also compared early SABRE and delayed wedge resection in patients without no comorbidity. In this analysis, yeah, as you can see here, early SABRE showed superior survival than SABR. Therefore, the authors of this study concluded that delayed surgery is better than prompt SABRE, even in COVID-19 for when patients treatment should be delayed due to COVID-19 infection. Therefore, so to summarize, comparison between SABRE and surgery in prospective cohort study, but small number of patients study, SABRE is comparable with surgery, but large population study, but retrospective cohort, surgery showed superior outcome than SABRE. Therefore, yeah, I think, yeah, to conclude this issue, we need further study. In National Cancer Center, we prefer sublobar resection than SABRE if patient pitted surgery. Then, yeah, I'll move to next issue. Next issue is SABRE for centrally located tumor. So, in previous RTOG study, yeah, centrally located tumor, when PTB touching the central zone, and central zone means 2 centimeter expansion from lobar bronchus, then yeah, higher ablative dose RT resulted in more severe complication. So this is the example of SABRE complication in centrally located tumor. So patient received 50 gray in 5 fractions, and after the SABRE, yeah, patient died due to bronchial bleeding by radiation-induced necrosis, as you can see here. So, Nordic study tested the prolonged fractionation for centrally located tumor. So, in this study, 7 gray per fraction with the total 8 fraction. Therefore, the total dose was 56 gray of SABR was tested for centrally located tumor, and they separate tumor between A group and B group. Yeah, so as you can see here, B group is common centrally located tumor, and A group is indicating the tumor is located trachea and main bronchus and lobar bronchus. So I refer this A group as ultracentral tumor. So they total 65 patients enrolled, and 2-year local progression, local control was 83%. So local control is not bad considering the protracted schedule, but yeah, grade 3 to 5 toxicity was frequent in ultracentral group. So among 65 patients, 22 patients experienced grade 3 to 5 toxicity, and among 22 toxicities and 10 toxicities was grade 5. So in this picture, blue star indicates successful treatment without severe toxicity and recurrence, and green star indicate local failure, and red star indicate the treatment-related mortality. So as you can see here, the ultracentral tumor, the grade 5 toxicity is more frequent, and local control also, local picture was similar between groups. Anyway, the authors of this study did not recommend this fractionation for ultracentral tumor. Therefore, to summarize this issue, various SABRE regimen has been tested for centrally located tumor. For example, 50 gray in 5 fraction or 70 gray in 10 fraction. In high-loss trial, 56 gray in 8 fraction. that is BED 187 gray, but this dose was risky for ultracentral tumor. Therefore, yeah, I prefer 60 to 66 gray per 15 fraction for ultracentral tumor. This is just my opinion. Yeah, this, in my experience, this dose is safe. I didn't experience the treatment-related mortality in this dose fractionation schedule. But as you know, yeah, this is suboptimal dose. Therefore, yeah, this treatment regimen cannot produce best local control rate. But I prefer low toxicity. Therefore, yeah, I prefer this fractionation schedule. Next issue is single fraction versus multi-fraction saver. Yeah, so RTOZ 915 study tested single fraction SABR of 34 gray in single fraction, and 48 gray in 4 fraction multi-fraction schedule. Therefore, yeah, total 39 patients enrolled to single fraction saver and 48 patients enrolled for multi-fraction saver. In progression-free survival, yeah, 48 gray in 4 fraction multiple fraction saver showed better progression-free survival, but this result was not statistically significant. In regarding overall survival, multi-fraction saver showed slightly better overall survival, but also this result was not statistically significant. Therefore, yeah, this study is concluded that yeah, single fraction saver is durable treatment for peripherally located stage 1 non-small cell lung cancer patients. But yeah, as you can see here, although that is not statistically significant, the progression-free survival and overall survival was better than multi-fraction saver. Therefore, yeah, in maybe the more power with the larger patients number, yeah, this result can be changed. Next, I'm talking about Saffron-2 study. Saffron-2 study was randomized trial, also comparing single fraction and multi-fraction saver for lung cancer. But in study, the patients have oligopulmonary metastasis. In this study, 44 patients assigned to single fraction saver, 28 gray in single fraction, and 43 patients enrolled to multi-fraction saver, 48 gray in 4 fractions. According to this study, overall survival and freedom from local failure and disease-free survival and multi-disease-free survival is it was similar between single fraction and multi-fraction savers. This study is a review article, and in this study, the authors showed the prospective clinical trial for comparing single fraction saver and multi-fraction saver in early stage lung cancer and oligometastatic lung cancer. So currently, there is no prospective clinical trial show the difference between single fraction and multi-fraction saver. But as I said, the enrolled patient is small. and this study is just phase 2. So I think so. It is hard to conclude single fraction saver can produce the same outcome with multi-fraction saver. Anyway, single fraction saver can be considerable treatment for stage 1 lung cancer and oligometastatic lung cancer patients. So single fraction saver has shown comparable clinical efficacy when compared with multi-fraction saver. But yeah, I recommend single fraction saver for highly experienced physician. And recent pattern of care for stage 1 lung cancer and oligometastatic lung cancer popularized to multi-fraction saver than single fraction saver. That may be due to current reimbursement policy. So finally, I'm talking about techniques and proton beam therapy for stage 1 non-small cell lung cancer. So yeah, first I'm talking about the outcomes of proton beam therapy in National Cancer Center in Korea, and this study was performed with Unurjargal Bayasgalan when she stayed in Republic of Korea. So in this study, we analyzed 42 patients treated with proton beam therapy. And the prescription was various according to the tumor location. So for centrally located tumor, we prefer 70 gray in 10 fraction, and peripherally located tumor, we prefer the 60 gray in 4 fractions. And when tumor located close to brachial plexus and close to chest wall, then we also adjusted the total radiation dose. So in our study, local progression-free survival was 91.5%, and 3-year overall survival was 71.8%. So saver using proton beam therapy produced good outcomes. Next study is dosimetric comparison between proton beam therapy and 3D CRT and static IMRT and VMET. So this figure shows the dosimetric distribution of proton beam therapy and static IMRT, 3D CRT and static IMRT and VMAT treatment. In 3D conformal radiation therapy and proton therapy, we allow the narrow lateral margin and long superior inferior margin to reduce unnecessary radiation exposure to lung. So we divided patient to according to tumor location. So therefore, patient categorized to central and peripheral and close to chest wall. In first row figures shows the mean lung dose of each treatment. So as you can see, central and peripheral and the tumor close to chest wall, proton beam therapy showed lower radiation exposure, but dose distribution here. And in V5 dose, also lower in proton beam therapy. And this difference in V5 is maintained in central and peripheral and cross-chest wall tumor, but the difference is most higher in centrally located tumor. In comparison of heart dose, the proton beam therapy showed lower mean heart dose and lower V5 dose, and this benefit of proton beam therapy comparing other treatment techniques. Yes, the central located tumor showed better larger proton beam benefit compared with the other locations. So in this table shows the other dosimetric statistics, including spinal cord, pulse, and chest wall. So in centrally located tumor, proton beam showed better dose distribution for spinal cord and pulse, and this also maintained to close the tumor close to chest wall as well as peripherally located tumor. But 3D CRT, IMRT, and VMAT also produced acceptable dose distribution. So to summarize this dose comparison, proton therapy provides better organ preservation in lung, heart, and pulse and spinal cord. And this benefit of proton beam therapy was higher in central tumor. This is a current practice in National Cancer Center. We draw GTB and IHTB using 4D CT. Then we also use motion management, Barian, RPM. So radiation being delivered in respiratory phase of 40% to 60%. Therefore, in regular case, peripherally located tumor, 6th grade infofraction is our standard prescription, and tumor located around the high risk area, for example, chest wall, we prefer compromised those 50 grade infofraction or 70 grade in fraction. But as I said previously, in tumor is ultracentrally located. Tumor touch, the PTB touching trachea and main bronchus. We use more protracted radiation schedule than this. So I show the case of stage 1 non-small cell lung cancer treated with proton beam therapy. As you can see here, these patients have a severe pulmonary fibrosis. So FEV1 was 75%, and DLCO is severely bad, 40% of prediction. So tumor located in right lower lobe, as you can see here, and patients received proton beam therapy of 50 gray in 4 fractions. So after 1 year of proton beam therapy, you can see radiation fibrosis here, but patient didn't experience the symptomatic toxicity by proton beam therapy, but patient died due to liver and bone metastasis. Next study is Korean multi-institutional retrospective study. In this study, so proton beam therapy is operating in National Cancer Center and Samsung Medical Center in Republic of Korea. So these we compared the treatment outcome of proton beam therapy and photon beam radiation therapy for stage 1 non-small cell lung cancers in these two institutions. So 93% of National Cancer Center and 196 patients of Samsung Medical Center with stage 1 non-small cell lung cancer was analyzed in this study. So the tumor location was various. Therefore, as you can see here, those prescription is really various. So centrally the 3 gray of 20 fraction. And in peripherally located tumor, 50 gray over 4 fraction, total 60 gray was most frequently used. So among 289 patients, 177% treated with proton radiation therapy, including 3D conformal radiation and IMRT and VMET, and 112 patients treated with proton beam therapy. So the overall outcomes of this figure shows overall outcome of patients. So 2-year overall survival was 83%, and 2-year progression-free survival was 71%, and 2-year local control rate was 94%. And in univariate and multivariate analysis, we performed the univariate and multivariate analysis, and in multivariate analysis, adenocarcinoma showed better local control, and BED exceeding 125 gray showed better local control. But proton beam therapy was not significant factor for local progression-free survival. This table shows univariate analysis and multivariate analysis for overall survival. Also, proton beam therapy was not significant factor for overall survival, but female patients and higher BED over 125 gray was significant factor for overall survival. And next, we performed the propensity score matching. In propensity score matching, proton beam therapy didn't show superiority in terms of progression-free survival, progression-free survival, and overall survival. In dosimetric comparison, proton beam therapy showed lower mean radiation long dose and lower mean heart dose. In analysis of complication after propensity score matching, proton beam did not significantly reduce the radiation pneumonitis, non-cardiac chest pain, and rib fracture. But overall symptom of aggravation were lower in patients treated with proton beam therapy, but this result was not significant. Therefore, I think we need the future prospective trial, also evaluating patient-reported outcome to compare photon and proton beam therapy. To summarize, radiation technique, 3D conformal radiation, static IMRT, and VMET showed satisfactory dosimetric outcomes for stage 1 non-small cell lung cancer. But proton beam therapy showed better organ preservation of lung and heart. And the benefit of proton beam therapy can be maximized in centrally located stage 1 non-small cell lung cancer. Anyway, yes, radiation with higher BED resulted better outcome, and yeah, further study is needed to develop the protocol for PBT for central and ultracentral lung cancer. Yeah, this is the end of my presentation, and thank you for listening.
Thank you, Dr. Yangonsa, for your excellent presentation. So now I would like to move toward our delegate panelists from comments and the questions and their personal experience with the proton versus photon therapy for non-small cell lung cancer. And afterwards, we will answer any questions from the audience. So now I would like to request Dr. Srinivas Chilukuri to have your comments and questions. So please, Dr. Srinivas.
So it was a very nice presentation by Dr. Su, and a nice overview of all the key elements for anyone who is practicing SABR in the clinic. I too don't like to call it SBRT. I too like to call it as SABR, but of course I these days I'm calling it extremely hypofractionated treatments. So one question which I, as a proton therapy user, I'll make a few comments later, but one key question is, for, of course, dosimetrically speaking, the challenging ones are the ones which we also treat on protons. Of course, in a bad lung, you showed an example, but in central and ultracentral tumors where things can get challenging with conventional photon-based treatments, we too prefer protons. But protons also, we need to keep it in mind that there are some biological uncertainties, and therefore, are you doing any kind of a variable RBE or LET-based evaluation or optimization for patients who are receiving protons, especially in these central and ultracentral tumors, Dr. Su?
Oh, that is a good question. Usually we consider RB of proton is 1.1, but yeah, the edge of SOBP, the RB increased up to 1.4. But yeah, unfortunately, yeah, we don't have the model for calculation of increased RB in distal edge. So as you said, so RB uncertainty is present in distal part of SOBP. So yeah, I think the use of proton beam therapy is cautiously performed in central tumor.
So I agree that we do the same. We have means to now based on, of course, RB modeling we are not using because there are so many controversies about it, but the physical parameter, which is linear energy transfer, is a physical parameter, and therefore that can be incorporated, that can be evaluated a little bit to a reasonable extent, of course. And even plans can be optimized based on the LET, and therefore, so for those, of course, for majority of the audience who are not using protons, I think photon-based SABR approaches are excellent. Even in proton centers, we do more common photon-based SABRs for most lung cancer patients, most stage 1 patients. But there are certain exceptions where the patients could have central tumors or ultracentral tumors. Patients could be undergoing re-radiations. Patients of interstitial lung disease or extremely bad lung function, or patients who have multicentric disease, multiple tumors on both sides of the lung or even the same side of the lung. Those who have poor cardiopulmonary reserves, these would be good candidates as of today to evaluate proton beam treatments, proton-based SPRTs or SABRs. We do, as Dr. Su mentioned, we also do extreme hypofractionation. Our preferred go-to regimen is 16:5 for most proton patients. Of course, in patients who have central tumors, we do give 7.5 × 8, which is also just a BD of 100 gray. For ultracentral tumors, I too agree with Dr. Su that 16:15 or 66:15 is our go-to approach as well, either with protons or with photons. We, as I said, for patients, for us to use protons routinely, there needs to be more prospective data, more longer follow-ups, a larger patient database to say that protons is an option in generally in all patients. As of now, we are limiting ourselves in patients which challenge us, which are extremely difficult situations to handle, and therefore we use protons in those patients. Other than that, I think we, as Dr. Su mentioned, we are a bit cautious while using protons for central and ultracentral tumors. We are doing everything possible to mitigate or minimize uncertainties, both physical and biological uncertainties. We are using respiratory motion mitigation, motion management strategies. We do use breath holds as well as free breathing with ITV base, but because the interplay effect is a significant factor, especially in pencil beam scanning systems, it is important that we use rescanning techniques to minimize or mitigate the motion. The last but not the least, I would also like to mention is most data for lung cancer exists on a passive scattering platform. There is now data that with pencil beam scanning, the doses can be even more conformal than passive scattering, although the interplay effect is a significant factor when we use pencil beam scanning. But number of prospective studies are now showing that it is safe to use pencil beam scanning with or without rescanning techniques, which gives an additional advantage over and above passive scattering. And fortunately, we are currently using that techniques. So with that, I would like to finish my comments, and I would like to thank the organizers for this opportunity.
Thank you, Dr. Srinivas, and for your experiences. And I think that's very helpful for our countries in the Asia. So I would like to move forward to next panelist. I would like to request Dr. Hideyuki Harada for your comment.
Yes.
Yeah. Please.
Thank you. Thank you for nice lecture from Dr. Su. And my question is a similar question, but it is proton therapy for lung cancer is not yet covered by public insurance in Japan. But I know in Korea, public insurance covers proton therapy. So how do you decide whether to apply for SABR or proton in clinical practice? How do you decide which patient, this patient is a proton and this patient is a photon? How do you decide?
Oh, yeah, thank you for, nice question. So, I think, SABR is best treatment in most patients. So proton is expensive treatment. So it is important to define optimal patients for proton beam therapy. So I prepare the I think the tumor location is important. So in the lung, bragg peak is degraded in the lung. So proton beam is stopped in the air. Therefore, I prefer that the tumor is closely located to mediastinum, especially centrally located tumor, I prefer proton beam therapy than a saver.
Yes, I agree with your opinion. I also think the proton therapy is effective for patients with close to heart or mediastinum or large lesion, or the patient who have multiple regions or in irradiation case. But in general, but you say the patient-related outcome is important in future study. I agree with your opinion, but it is important as the cost-benefit analysis on proton therapy. Do you have any data as the cost-benefit analysis between photon saver and proton therapy for stage 1 lung cancer?
Oh, that's the important, very important question. So yeah, we try to that, but until now, the proton beam therapy is only operable in 2 institutions in Korea. Therefore, we think we don't have enough patients. Therefore, yeah, it's in our plan, but not yet.
Thank you.
May I comment?
Could you wait for?
Sure.
Please, thank you. And thank you for your comments and the question for Hideyuki Harada. And I would like to move forward to the next panelist. I would like to request Dr. Uranchimeg Tsegmed from Mongolia for your comments and questions. So please, Dr. Urna.
Thank you very much. So today's topic was a very great topic, which is a very, we learned a lot from the developed countries' advantage technology from the presentation. So in our country, one of the low and middle income countries, so we now forward and to introduce new advanced technology, LINAC-based technology, including SABR. So there are so many evidence, but all of the prospective trials usually pays to, so that's why the number of the patients are not so enough, and depend on the also the group which is their interest. So results could be somehow induced. The example, there are so many like institutional, multi-institutional results show the BR is almost the same result show compared with the surgical lobectomy in the early stage of the lung cancer. Some the study shows all the overall survivals can show the little bit the superior result. But however, some of the study results shown we saw from the professor's presentation, there are the disadvantage or the little inferior result compared to lobectomy in early stage the non-small lung cancer. So what do you think? My question is that what do you think about the outcome of the studies comparison between SABR and lobectomy in early stage lung cancer? It can be induced by the group's interest. What do you think? This is my question.
Oh yeah, that's a good question. So that's very important. Yeah. So in retrospective larger patient number study, then they perform the propensities, although they perform the propensity score matching, I think the patient characteristic is bad in SABRE patient than patient received the lobectomy. So I think some cause of inferior outcomes of SABRE are oriented from that. But yeah, so that is anyway in lobectomy. So in lobectomy, totally remove involved lobe and mediastinal lobe dissection is also performed. But SABRE just treat yeah, primary tumor. Therefore, I think lobectomy with mediastinal node dissection is better treatment for surgically fit patient. But yeah, in surgically unfit patient, SABRE is yeah, treatment of choice.
Thank you very much. The second question is regarding to comparison between proton beam and proton beam therapy, like a comparison between SABR with the proton. So we can see the result regarding to overall survival and progress-free survival. There are none of the difference, right? So the also you show the advantage, especially centrally located. The proton beam therapy has a advantage, especially for the heart, like more the tissue, which is the near to the like muscle or tissue. So how about the those distribution in the lung? Is there compared to the tooth method? Is there any differences or they are similar? So
for long
Oh, the
dose, for long
advantage,
dose,
like-
yeah, for long, yeah, dosimetric outcome is superior in proton, but yeah, as previous panels said, these outcomes did not consider the LAT and LAT and BT factor. Therefore, I think if this LAT and BT factor is considered, then the benefit of proton for preserving lung tissue may be decreased. So I think so I think the dosimetric outcome is overestimated. But according to tumor location, for example, tumor located close to mediastinum, so proton beam can be stopped in the mediastinum. Then, yeah, proton beam may be helpful to reduce the lung dose.
Very much.
Thank you, Dr. O'Neill, for your questions. So I would like to move on to the comments and the questions from the audience now. So we're getting out of time, but there's two questions written in the chat. I would like to ask those questions beforehand and move on to the audience to speak. So first question is from Aliyah Shanas. They want to know the cost of the proton beam therapy from the Bangladesh. Dr. Saul.
Oh, yeah. So in Republic of Korea, the proton beam therapy for lung cancer is reimbursed by the national insurance system. So the patient cost just 2,000 USD, but in foreign patient, for example, for foreign patients, the cost for proton beam therapy for stage 1 lung cancer may be maybe 30,000 USD.
30,000. Okay, I think that answered your question, Aliyah Shanas. So I would like to move forward to next question from Endan Nuriyai. There's a technical question for the photon-based saber, I think. Do you prefer non-coplanar technique, or can it be done in helicotype of LINAC, tomotherapy, or Hasian? That's the first question. And the next question is, what energy do you use? 6 megavoltage or sometimes 10 megavoltage? And thank you.
Oh yeah. For first question, in early use of Saber, we also use the non-coplanar beam. In 3D conformal plan, when we use non-coplanar beam, then we can use about 20 beams for Saber plan. But and when we don't use non-coplanar beam, we usually use 10 beams for Saber plan using 3D CRT. But I didn't find the difference between 20 beams and 10 beams. So I think non-coplanar beam can result in better dosimetric outcome using more number of beam. But I think in 3D CRT technique, about 10 beam is 10 beam is sufficient to produce good outcomes. In second question, I prefer 6 map because 10 map when we use 10 map, the penetration of beam, those radiation exposure to contralateral lung and other important organ is increasing. Therefore, I prefer 6 map photon beam.
Okay, Doctor, thank you for Dr. Saul for answering the questions. So I think that's it for the Q&A and I've written in the chat box. Now I would like to ask from the audience, is there any questions or comments? If you had, raise your hand.
Make a comment.
Oh, yes, Professor Nagata.
Thank you, Dr. Saul. Very nice presentation and very nice review. I just want to make a comment that, recently, thoracic surgery in Japanese, they performed JCOG 0802 trial. And the conclusion showed that, segmentectomy was better than lobectomy for early stage lung cancer. So thoracic surgeon going to prefer, less invasive, surgery. So the comparison between SBRT is not lobectomy, maybe segmentomy in future. So we should try to improve our, local control rate. And so in Japan, we are pursuing the JCOG 1408 trial to increase dose and to increase local control rate. So I think, it is our future, we should, thoracic surgeons are going to make better clinical results, and we radiation oncologists should pursue the more better clinical result with less invasive technique. Anyhow, SBRT for early lung cancer is widely clinically available in Asian countries, and I'm very happy we can share the benefit of SBRT for early stage lung cancer. Thank you very much.
Yes, thank you so much, Professor Nagata. So there's another question from the audience, Manan. They asked, do you see 50% isodose line in SBRT?
Oh yeah, sure. So I don't remember the exact criteria, but in RTOG protocol, yeah, there is criteria for 50% of isodose. So maybe 4 to 6 folds of PTB. So I also check the 50% of isodose, right?
Thank you. I think that covered your question. And there's one more question. Do you do preventive treatment for poor lung capacity before proton therapy from the Mongolia, I think? Dr. So.
Oh, okay. So, I when patient FEV1 less than 1 liter, yeah, then that case is risky for even in proton beam therapy. The patient symptom is yeah, aggravate. In many cases, patient symptom is aggravated after treatment. So yeah, I don't recommend if patient have poor FEV1 for stage 1 lung cancer.
Okay, thank you for your answer. I think that covered the question. Is there any more questions from the audience or comments? If you do have, please ask, because we're getting having out of time right now. So, one more question. From the alien Hudia. In resource-constrained area exam, for example, non-40 CT simulator LINAC with 1 centimeter MLC width, but without CBCT verification on abdominal compressors, what is your take on SABRE versus conventional fractional given to the superiority of SABRE result?
Yeah, that is very difficult question. So, oh yeah, without convincing, I recommend to check patient respiratory motion using fluoroscopy. So, if a patient respiratory motion checked in fluoroscopy less than 1 centimeter, then I think SABRE can deliver for that patient. But if patient respiratory motion more than 1 centimeter.
Okay, yeah, thank you. I think it's a very important question. So in resource constrained area, usually like some countries below low income countries, we don't have a 4D CT simulator. So I think that covered every questions, and thank you, Dr. Sao. Is there any questions from the audience? So I think, yeah, there's no more questions. So I would like to close our webinar. So I would like to specifically thank for our speaker, Dr. So-Young Won, for his excellent presentation and contribution to our webinar. And also I would like to thank our panelists and for their contribution and their questions and everything. And I think there's one more question, but I think that was a comment. So now I would like to announce the closing of our webinar. Thank you, everyone, and have a good evening.
Bye.
Bye-bye. Thank you.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Thank you very much, everyone.
Bye.
Thank you, Unro, for your moderating.
Good
Thank you very much for having me.
Okay, bye-bye.
Thank you, bye.